Hi, I'm Dr. Raj Gopalan, the founder and CEO of BSRM Consulting. I'm delighted to be here, at least virtually in Baltimore at the International Congress on Neurology and Brain Disorders. I was in person last year in Boston for the same conference, and I wish I could be here in person as well this year, but unfortunately, because of the travel plans, I couldn't be here. But I'm really delighted that the conference management was willing to accept my video presentation so that you all can listen to it. And then if you have any questions, please do send those questions to me so that I can engage in a response to those questions with you. Let us jump right in. Hope you're able to see my screen. So to start, let me give you a brief bio of me so that you can understand where I'm coming from, what my background is. I'm currently a CEO and a founder of BSRM Consulting. It's a healthcare intelligence company. And I have about 35 years of experience building and deploying CDS and digital applications used in healthcare professionals. And I'm also an expert in on AI and ML. So before this, I was working at the Siemens Healthineers as the Chief Medical Information Officer and the Global Head of Clinical Decision Support, where my focus was on AI, ML applications on blood and their blood results. And then I continued to develop on that, and I'm able to do a phenomenal amount of work on this particular area, and you're going to listen to just one aspect of it. Before that, I was the VP of Innovation and Clinical Informatics and Data Science at the Wolters Kluwer Health. You all know up to date, which most of the physicians use on a daily basis. So that company is Wolters Kluwer. So I was at the innovation department. Before that, I was the corporate medical director and the regional CMIO for Advent Health System, which is a large multi-hospital delivery network based in Florida and also 9 states. I was involved in rolling out the CPOA system there in about 23 of their hospitals. Before that, I was at the UNC Healthcare System as the director of medical informatics and product development. I was involved in actually designing, developing, building, implementing, and optimizing an electronic medical record system before even the Epic and the Cerner were there. So that was, well received, well accepted, with about 80% adoption right from day one. And it was later acquired by Siemens Health Solutions. So that's a proud moment. Before that, I did my medical informatics training and a fellowship at the University of Pittsburgh Medical Center, where I actually got trained as an informaticist formally, and focusing mainly on artificial intelligence and machine learning for the delivery of healthcare applications, specifically for physicians delivering care at the bedside to their patients and also in their clinics. Before that, I worked for the iKnowMed Systems, again, building artificial intelligence systems for clinical trials, mainly, enabling the software actually helps to identify patients who are eligible for, specific clinical trials. Before that, I was at the Oasis Healthcare System as a clinical architect, again, building components of the electronic medical record system. Before that, I was a clinical faculty fellow at the University of Maryland Medical Center, mainly research as well as teaching residents. And before that, I was a clinical fellow at the National Cancer Institute, mainly working on breast cancer. So as I said, I'm an MD in general medicine, mainly focused on internal medicine. And I also have a master's in information science, specifically focusing on AI and machine learning. And I also have a bachelor's in computer science from the University of Maryland, and I have professional certifications, extensive professional certifications in AI and machine learning. So that'll give you a gist about my background. So the topic today is brain tumor. As you know, the brain tumor The prevalence rate is 0.01%. It's a small percentage though, but 1 million Americans are living with brain tumor today. And brain tumor accounts for about 1 in 4 childhood and adolescent cancer diagnosis. So as you can see, the importance of this. And if you look at the age of the diagnosis of brain tumor, even though it is very common in the childhood age, the age of diagnosis actually peaks at around 60 to 70, 75 years. And if you look at the male and the female members, it kind of follows the same pattern. Males are slightly more prone for developing brain tumor than females. And if you look at the 5-year survival rates for brain tumors, and it also depends upon the type of tumors, glioblastoma is actually a very nasty one. And if you look at the survival rate, is just around 10% or less than 10%, followed by anaplastic astrocytoma, low-grade astrocytoma. And then, of course, if it's ependymoma, meningioma, and oligodendroglioma, all that have, a good survival rate, about, 70 to 80%. I myself have seen patients suffering from glioblastoma. We see quite a bit of that recently. Some of them, some of the research attributes that to the cell phone use. There is no direct connection between the cell phone use of the glioblastoma, but that is something that we have to be watching. And if you look at the CNN tumors of relative frequency, even though glioblastoma, survival rate is very short, but unfortunately, that forms pretty much half of all the brain tumors. So if you look at it, it's about 48%. So that is why, even though the total prevalence of brain tumors is 0.01, predominantly half of that is glioblastoma with a very, very short survival rate. So that is why it's actually important to talk about brain tumor. That is why I chose this topic, and how AI and machine learning can help in identifying a brain tumor very early. And most of these tumors, as you know, are very, very silent, and the symptoms are not very specific. So physicians tend to miss them. And when they're diagnosed, it's kind of late in the disease, and then it'll be very difficult to kind of control and manage those patients. So if you look at the distribution of brain tumors across the world, European region is actually is the most common. The brain tumor is very common in the European region, and the mortality rate also follows actually the incident rate. And then, of course, the lowest is actually the African region. So if you look at it, in a way, the brain tumors are more common in the developed countries rather than developing countries, which is also something which is important to note. So what I'm going to here talk about is how blood tests can help to diagnose diseases at a very early stage, not brain tumor, but even a lot of other cancers and chronic diseases. So, Your Blood Never Lies is a book that was written by James Laval, and it is a very, very interesting book, and the topic is very interesting. It says your blood never lies. So there's a lot of truth to it, because if you look at the blood test results, that are the most objective form of data in an electronic medical record. If you look at the physician's notes, imaging studies, reporting on the imaging studies, it's all generated by professionals. So it could vary slightly between, different professionals. Whereas if you look at the blood test results, even though you send the same blood samples to two different labs, and the results are, pretty much consistent within a, maybe 5% error range. So it is very, very consistent. And CDC has said that 75 or 70% of the diagnosis are made based on the blood test results, which is very important to understand, which is also very comforting because 70% of the diagnosis is made based on, a data that is very consistent, that is very reliable, which is the blood test results. So I focused on the blood test results in building AI and machine learning applications because you've heard a lot in the literature that AI and machine learning, there's a lot of articles on criticism for AI and machine learning in terms of bias and things like that. So so long as we base the AI applications on data that is very, very reliable, then the output of those models and AI models would also be reliable. So that is the whole idea. So that is why I chose specifically this field of blood and how we can explore to use those blood results in identifying diseases early. So that has primarily been my work in the last 3 years, and I've seen phenomenal results. And I presented last year at Boston on a stroke. So how to identify stroke. This is an acute condition 1 week before the stroke happens. It was well received. And here I'm just focusing on the brain tumor, how we can identify the risk for brain tumor up to 3 to 6 months before the tumor shows up. So, so blood never lies, and so as you can see here, blood is a window to human health and disease. So in short, that's exactly what my explanation was. So there is a very interesting concept that was put forth years ago by Charles Nunnenberg. It is called brain-to-brain loop concept. So as you can see here, as I said, 70% of today's medical decisions depend on lab test results, and 14 billion tests are ordered every year. So if you can look at, if you can focus on the workflow of how blood test results actually play a role in the diagnosis. So patient comes into your office and the physicians actually elicit the history, do a detailed physical examination, and then within the physician's mind, the physician will come up with a list of provisional diagnosis. And then based on that, the physician will order a bunch of blood tests. And in the US, they order panels, like lipid panel, CBC, differential count, things like that, and complete metabolic panel. And then once the blood is ordered, then the automation takes place. The blood is automatically kind of shipped to the lab, either through pneumatic tube system, if it is within the organizations, or through fast couriers, keeping the blood in a cold environment. And then it is identified using barcoding. It's actually labeled using barcoding systems. And then it's identified so that the tubes are not mismatched. And then it is transported, and in the lab, it's prepared, making sure that the quality is good and it's still in good shape. And then it is analyzed using advanced analyzers, which are state-of-the-art analyzers, which are linked with advanced information technology, robotics. So most of the blood samples are not even handled by humans. It is totally automated with robotics. And then all this analysis is done within like minutes automatically, and the results are being split out. And electronically, the digital results are sent back to the electronic medical record, to the patients, and then it is displayed for the physicians to actually see. So as you can see, there are kind of two loops. One loop is a manual loop where the physicians are actually, going through their mind figuring out what the patient may be having, and then actually ordering the test. And once the tests are ordered and collected, sent to the lab, the automated loop takes over and everything else is automated until the results comes back to the electronic medical record. Then again, the manual process takes place and the physicians actually look at all those results, like 30, 40 of those results. They look at one result at a time. And as you know, majority of the results are actually color-coded based on whether they are within the reference intervals or outside the reference intervals. So the physicians only focus on anything that is highlighted if it's anything outside the reference intervals, and they only look at one test at a time. But unfortunately, what I have learned using my long research using machine learning and artificial intelligence is that individual reference ranges of individual testing doesn't contribute in identifying diseases early. Maybe if the patient's in an advanced stage and the results are very high or low outside of the reference ranges, it may have significance. But if majority of the results are like within the normal reference ranges or even riding on the edges, does that mean that the patient is normal? Because a human brain can only comprehend or process up to 3 results. So nowadays, the panels of 30 to 40 results, going through each one of them, and figuring out what exactly may be going on with the patient is actually a multi-dimensional problem, which the human mind is not equipped to do it. That is where the AI and machine learning can help tremendously, because they are designed and they are built to be able to tackle this multi-dimensional problem. They're able to crunch a lot of numbers, and the blood test results being numbers, arithmetic, they are able to look at thousands and thousands of past blood test results and what they ended up with, cancers or chronic diseases, and be able to identify the pattern of the blood test results, not one blood test at a time, pattern of all these 30 different blood test results, and we'll be able to give you a clue to us what may be going on with the patient so that we can continue to do additional testing. So that is the beauty of this. So as you know, missed and delayed diagnosis in the ambulatory setting is a huge problem. About 29% of the diagnoses are wrong diagnosis, because not to blame the physicians, because their load of patient volume is phenomenal. They got to see a typical internal physician usually sees about 30 to 40 patients a day, don't have a lot of time. On the top of it, they have to document all this in the electronic medical record systems. They hardly get any time to actually spend quality time with the patients. So that could result in not being able to elicit all the signs and symptoms. So misdiagnosis is a huge problem. So what happens to misdiagnosis is not only the harm, it could result in unnecessary testing, unnecessary procedures being done to the patient, but it can also lead to lawsuits, multi-billion-dollar lawsuits to the organizations. So one of the important things that we can do is, or even the technology can do, is able to help physicians, especially on a busy schedule, to support and remind them of things that they may want to look at that they may have missed. So that is the beauty of this. Okay, this is just a depiction of a machine learning architecture. What I'm going to say is probably it's not done based on this particular architecture, but you must have heard deep learning, quite frequently these days. So this is just to give you an idea that this shows that number of that with 5 layers, 6 layers actually, starting from the input layer on the leftmost side, as you can see here. The input layer, you input. Let us say if you're looking at the blood test results, let us say we are inputting about 8 different results like hemoglobin, RBC count, WBC count, sodium, potassium, calcium, albumin, and cholesterol. Then it goes through links that completely connected with the first hidden layer, the second hidden layer, the third hidden layer. And because they're completely connected, you can see the number of connections between those nodes. And then ultimately, it comes out to an output layer, which actually tell you whether this patient has either stroke or the patient has brain tumor or whatever it may be. So, so how can it do that? It actually learns the pattern of thousands and thousands of patients, past patients, who had ended up with stroke or no stroke, or ended up with brain tumor or no brain tumor, and it learned the pattern. And those knowledge is actually stored in these links. It's kind of like a brain. It is actually, the machine learning is actually modeled based on the human brain, because humans actually learn by pattern recognition from an infant. We slowly acquire knowledge because you're born with a kind of a blank slate, and then we are being taught by the mom, by the dad, by our friends. Constantly we learn, and then we are rewired in the brain about what we learn, and then we are able to process it, and slowly we start building those knowledge in the brain. So the AI and machine learning models are actually based on that. We are actually presenting multiple example scenarios to a machine learning model, and it learns. And once it is completely learned, then it is able to tackle a problem that is brand new. And then it is able to perform exceptionally well. Certain data is more, it lends more to do that. And one of the things that I found is that the blood test results is one of those which can lend itself very well to a machine learning model. Okay, so here you can see the model that is being used to predict brain tumor by routine blood test 1 week to months before diagnosis. Okay, all the way, right? Here on the top right-hand side, you can see the list of markers that are being used to build this model and to be able to use to predict whether the patient has brain tumor or not. And the bar graph, the height of the bar graph represents which marker is important, predominantly important in terms of priority that the model used in predicting whether the patient are likely to develop brain tumor or not. So you can see creatinine is on the top of the list, which is one of the key elements that determines brain tumor. Who would have thought that creatinine is a marker that is important in identifying whether the patient has a risk for brain tumor or not? We always associate creatinine with kidney functions, right? So that's why it's amazing that AI can uncover things that we never thought about. So that can open up phenomenal opportunities for medical research. So here, creatinine is found to be one of the important marker, followed by ethnicity, because brain tumors, as we also know, they're predominantly in certain ethnic groups than others. And then again, cholesterol total, white blood cells, triglycerides, eosinophil counts. As you can see here, the list of markers, and as the markers, we move to the right, the importance of the markers goes down. So, focusing on the first few markers, the top 5 or top 10, is important to find out that what markers are actually maybe contributing or maybe showing some indications of any kind of risk for brain tumor. So here, on the left side, talks about, it shows actually what is called an ROC curve, which gives us an idea about how accurate the model is, and which is called area under the curve. Here, as you can see here, it's almost like straight line, which means the performance was exceptionally high. At the bottom left, you can see what is called a confusion matrix that actually gives you break this down to the, breaks the performance of this model down to certain numbers that you can understand. So here, the way it is being done is that thousands of patient data is being used to train the model. In the training model, we use 50% of the data. Let us say we are using 10,000 patients. 5,000 patients are patients who developed brain cancer. And then 5,000 patients are the control patients who never developed brain cancer. So we look at those patients' blood test results and go back and look at the blood test results up to 3 to 6 months because they are diagnosed with brain tumor at the end of 6 months. So we are looking at the blood profile going backwards. And we are training a model with the combination of, the patients who develop tumor and the patients, control patients. And the model is able to identify the patterns that are more likely to develop brain tumor. So in this particular case, that after the model is completely learned, and then we test the model on population that represent the real population in the world, which means that here, as you can see, the testing group has got pretty much 486 patients with no brain tumor, and it's only 5 patients with brain tumor. So it's a very, very small percentage of patients with brain tumor. The whole idea is that whether the model is able to pick up those very, very small number, like a needle in the haystack, because that's extremely important for a model that is designed to do what is called population screening. So the whole idea here is that not everybody is going and screening for every cancer from the population, right? But they go for the wellness exam, they do the routine blood test once every year or so. So that is available, the data is available. So is it possible to use that data to screen patients for a risk? And then once the risk is identified, then we can always do additional specific testing. So in this particular case, so for that, we need to make sure that it's able to identify patients in the population because a very, 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 very small likelihood of developing cancer. So in this case, it's 5 out of 500, right? So it's almost 1%. So is it possible to identify that? So here, as you can see, the model identified pretty much every one of those 5 patients. So that is called 100% of sensitivity. Okay, it identified all of them. So it performed with 100% sensitivity. And then for the patients with no brain tumor, the control patients, it identified pretty much except one. So it's actually stamped one patient who didn't have brain tumor that most likely have a risk of brain tumor. That's okay. It's called false positive, but it is okay because that patient can undergo, imaging technique and things like that to be able to rule that out. Okay, but we don't want to miss any one of them because if you miss it, then that patient may not have an opportunity to do any kind of advanced testing. So, so this particular model has 99.79% of specificity. Specificity is ability to identify normal individuals in the population, and 100% sensitivity, ability to identify disease patients in the population. And on the right side, you have 2 markers. One is called the negative predictive value. So if the model says the patient has no brain tumor, and then the confidence is 100%, that is called the negative predictive value. So when the model predict negative value, saying that the patient doesn't have brain tumor, confidence is 100%. Whereas when the model says the patient has brain tumor, then that is the positive predictive value. It's 83%. So if you look here, out of, it actually labeled 6 of them as brain tumor, but only 5 of them had brain tumor. One of them is actually a normal patient. And that is why it has got a very, it's 83% positive predictive value, which is very typical in a population where the incidence or the prevalence of the disease is very, very small. like 1%. So the tolerance for false positive is fine because we are not unnecessarily missing any patients at all. So that is what the false positive is. So positive predictive value here is 83% because it just missed one. So but since the population of patients with brain tumor is very low, so that is why it's happened. So once the model predicts a positive predictive value, or when the model predicts that the patient may have risk for brain tumor, then you can always do the MRI, CT scan, PET scan, and MRS to kind of rule in or rule out the disease. And if the patient doesn't have any disease, then they can follow up after 6 months to a year. Ask them to, so at least they can put the patient on a radar to constantly go back and check. So that is the whole idea of this. Now, I also looked at, I said creatinine is one of the markers that was identified as the key component. So I looked at the average marker between the control patients and the brain tumor patients, going up to about 3 years, okay? 3 years before they were diagnosed. And as you can see, starting from about 12 months, you can see there is for patients with brain tumor, okay, the creatinine values is low, about 0.8, still within normal limits, as you can see, still within normal limits, 0.76, 0.77. So it actually went down from 0.95 to 0.8, okay, for brain tumor patients. For normal patients, it actually went up a little bit and then came down to about 1. Still, there is a gap between serum creatinine between, on an average, between patients with brain tumor and the patients with no brain tumor. So if you look at the cholesterol, normal is less than 200. As you can see, the brain tumor patients actually, about 6 months to 12 months before they developed brain tumor, it went up to 230 and then came back to normal. So if you look at the trend of that, so the trend line, if you look at it, for creatinine, it goes down, with time closer to the diagnosis. So 3 to 6 months before the diagnosis is actually, going down from all the way from 24 to 36 months before diagnosis to 3 months before diagnosis. Whereas in normal patients actually going up. Total cholesterol actually kind of staying kind of constant for no brain tumor, and then again it just goes up. The trend line at least goes up for brain tumor patients. Triglyceride, not much of a difference between the patients with brain tumor, no brain tumor. Again, lymphocyte kind of looks similar to kind of creatinine, where brain tumor patients as a lower lymphocyte count, not a lot, so like 19 here compared to 27, as you approach the diagnosis. Fluoride, again, there is a gap because the brain tumor patients tend to have a higher fluoride level, 103, compared to normal 102, not a lot. So that is why it's very difficult for the humans or the physicians to pick up those differences just by looking at one patient's chloride levels. Between 103 and 102 or 104 doesn't make a lot of difference because they're all within normal limits. They're going to be overlooked. But AA can look at combinations of all of them and indicates a pattern. Cholesterol, again, actually has, HDL cholesterol is actually a protective. So patients with no brain tumor has a slightly higher HDL cholesterol level rather than patients with brain tumor. Okay, so I talked a little bit about creatinine, right? So is there a scientific basis of the role of creatinine in identifying risk for brain tumor? So if you look at that, there are articles that has been published in the literature that shows the creatinine level varies from patients with brain tumor compared to normal. Here it shows a study using creatine chemical exchange saturation transfer, which is called CR-CEST MRI, found that creatinine levels were lower in brain tumor compared to normal brain tissue. Furthermore, creatinine levels decreased further as tumors progressed. So this indicates that creatinine metabolism may be altered in brain tumors, which is kind of phenomenal. The AI picked that, and if you review the literature, there are articles that has been published, actual, trial done, randomized clinical trial done, and able to identify the role of creatinine in identifying patients who are at risk of brain tumor or who has brain tumors. And another paper is also differentiating tumor aggressiveness. CR-CEST MRI study also found that more aggressive gliomas, which we say is the most lethal form of brain tumor, had significantly lower creatinine levels compared to less aggressive tumors. So more aggressive the tumor is, the less the patient has the creatinine levels. This suggests that creatinine levels as measured by the CR-CEST MRI, they help differentiate gliomas of varying aggressiveness, which is important to even identify, not only identify the risk of brain tumors, but also their aggressiveness. And then we talked about cholesterol. So what is the role of cholesterol in brain tumor? I have given like 5 points here. A meta-analysis reviews various studies to evaluate the association between serum cholesterol levels and brain tumor risk. The finding says that lower serum cholesterol levels may be associated with the increased risk of brain tumors, highlighting the need for further research to understand the relationship. A cohort study investigates the link between serum cholesterol levels and brain tumor incidence. It includes that high serum cholesterol might be inversely related to brain tumor risk, proposing that cholesterol may play a protective role in brain cancer development, which is also important. An article examines how different lipid profiles, including cholesterol levels, affect the risk and prognosis of gliomas. Again, gliomas. It finds that elevated cholesterol levels are associated with a reduced risk of gliomas, suggesting that a potential protective effect, especially in terms of HDL, which we saw. Review focuses on how cholesterol metabolism influences brain tumor development. It discusses the mechanism by which cholesterol could affect tumor growth, such as through its role in cell membrane fluidity and signaling pathways. There's another article on that. So, as you can see here, the AA and ML models can actually point to the routine markers that are being exploited by the model to identify patients with and without, or to differentiate patients with and without the risk for brain tumor. And then that can actually lead to, because this shows about correlations, okay, cholesterol or creatinine. You can see correlations between them, but correlations is not causality. So, but it can lead to medical research to go back and look into biochemical mechanism, what exactly is happening. That may be really very helpful to identify what may be going on, and that may open up the door for drug development, different pathways and, metabolites and things like that, where we can talk about, or we can explore, what drugs can be developed to be able to arrest those pathways and, inhibit those pathways that actually favors tumor development compared to normal individuals. Okay, so this is we talked about the lymphocyte as well. There is a difference between the lymphocyte levels between brain tumor and normal individuals. A systematic review and meta-analysis analyzes various studies to determine the relationship between peripheral blood lymphocyte count and brain tumor risk. The findings suggest that a lower lymphocyte count might be associated with an increased risk of developing brain tumors, possibly due to a weakened immune response. So immune response generally impact tumor development. So there are also the reference to all this findings at the bottom, the article that actually explains in detail the mechanism of action between these markers and the risks. And HDL cholesterol, I said HDL has a protective mechanism. So here says the systemic review and the meta-analysis investigate the association between serum HDL cholesterol level and the risk of brain tumors. The analysis finds that higher HDL cholesterol level may be associated with a reduced risk of brain tumors, suggesting a potential protective effect of HDL cholesterol. Another study examines the relationship between HDL cholesterol levels and glioma risk and prognosis. The findings suggest that higher HDL levels are associated with a lower risk of glioma and better survival outcomes, indicating that HDL cholesterol might play a protective role. Hi, I will stop here because we are almost time. So I'd like to, get your feedback on this presentation. You may have a lot of questions, comments, and suggestions. So if you have them, please email it to the email that is shown here, raj.gopalan, my first name and last name, raj.gopalan at BSRMconsulting.com, raj.gopalan at BSRMconsulting.com. So if you send me the questions there, I'll be able to look at them and respond to that. So hope you enjoyed this presentation. I would love to be there, hopefully next year, wherever that is going to be. And we can definitely, discuss that. And any of you have any additional, things that you're working on that you want to share with me, please let me know. Hope, you're enjoying the conference, and wish you all the best and have a wonderful time the rest of the conference. See you all hopefully next year. All right. Bye-bye.